to really talk about something I feel very, very strongly about is, and the way that we can better understand myeloma and get closer to the cure for myeloma is understanding diverse populations in myeloma. So what we're going to talk a bit about statistics of race and ethnicity in myeloma, the differences in myeloma risk and biology, some of the chromosome, genetic, molecular alterations that are different, and then disparities in clinical trials, and then conclusions. And the big question I get is, why should we care about social populations in myeloma? It's because if we only look at certain populations, we get a very narrow view of what's going on with this disease. Because I think we had talked about this morning that is multiple myelomas, that people have very, very different courses and very different outcomes in myeloma. And the more people that we have involved in myeloma research and understanding, the broader scope that we get, the more it's applicable to everyone. And the closer we'll get to curing this disease. So the overall incidence of myeloma is more common in men than in women, but I think that what is striking is that and it's kind of hard to see there, but the incidence of myeloma is twice as high in people of African descent than it is in Caucasians, Asians, and people of Hispanic descent. And part of the reason, and that is actually a phenomenon that's around the world. So it's not just it's not just African Americans, but this has been known there's a paper written in 1960s in Jamaica saying that the incidence was so much higher in people of African descent in South Africa. So it is not just an African American issue. In the United States, a little over 20% now of the myeloma population is African American, with 65% being white. And blacks have twice the incidence of myeloma than whites. And we'll talk about how that is because of the higher incidence with MGUS. And again, blacks have the highest risk of myeloma than any other population in the world. And actually, the incidence dramatically rises with age in people of African descent, in that this is 16 per 100,000. It rises to 85 per 100,000 of black men over the age of 80. This is the SEER database showing that African Americans are on this line, that the incidence has been rising for everybody, but a bit higher for people of African descent. And the mortality, thank goodness, in myeloma has been decreasing for everybody, but still people African Americans have a higher mortality than other racial groups. And this is the largest survival disparity in the United States in cancer. And so, which is, again, an important thing for us to address in order to save lives. There was a study that was done, a national study, the Haynes study, that looked at almost 13,000 people over the age of 50. And they found that the incidence of MGUS was significantly higher in blacks compared to all other groups. And you can see the blacks are here and other ethnicities are there. And that blacks had an earlier onset of MGUS than other racial groups, and that the Haynes study was unable to correlate that risk with tobacco use, education, socioeconomic status, autoimmune disease, chemical exposures, and maybe with increasing weight and increasing BMI. So, the usual suspects of that disparity, social construct disparities, really aren't driving what the higher incidence of MGUS and ultimately myeloma between the races. Studies demonstrate that actually the family history is a stronger component in people of the blacks and whites, and that a molecular study looked at again found that the family history connection for MGUS and myeloma is stronger than in blacks and in whites. And a meta-analysis that was done looking at a suspect loci for that increased risk found out that there are distinct molecular differences in those loci between blacks and European Americans. Again, showing that there are biologic, cytogenetic, and molecular differences between black people that have myeloma and Caucasians that have myeloma. In a VA study, and this is an important point, in a VA's, I think they're all important points. So I shouldn't have said that. In a VA study, they found that the incidence of transformation from MGUS to myeloma was similar, but a recent SWOG study of 17% of that includes 17% blacks, myeloma was significantly lower in blacks and in non-blacks. And when they looked at a genomic risk profiling, that actually the higher risk profile was lower in African Americans than in other ethnicities, saying that that maybe again that there are genetic differences between blacks and whites that have myeloma that have a less prevalence for those high risk factors that would drive myeloma. So again, differences. There are also differences in presentation, that black patients present 4 years younger than their white counterparts. That pool data of newly diagnosed patients found that black myeloma patients are more likely to be anemic, more likely to have higher LDHs, which is part of our staging criteria for myeloma. And that in a SEER database that black myeloma patients had higher risk of the myeloma defining events, the hypercalcemia, renal insufficiency, and anemia, not so much bone fractures, which are higher in whites. And that's because another difference between blacks and whites, the blacks have a higher bone density than whites, therefore they have less lytic bone disease and fractures. There are also differences in chromosomes and cytogenetics. And I'm going to say, this is really interesting too, but it is really interesting. That the higher risk cytogenetic lesions are lower in blacks than in whites. And there have been repeated studies that have shown that the 17p, the additions of chromosome 1, the 414, monosomy 13, all those are lower in people of African descent or African Americans than in other groups. Which you would think would suggest that African Americans would have, these better outcomes. And in fact, when, that table didn't turn out well, but and I love this study, is that they looked at a geographical structure tool. What it does is you have patients that report their ethnicity, but this actually did genomic studies to prove ethnicity, and they had genes that were higher of African descent and genes of lower African descent. And those patients that had highest African ancestry more likely to have translocations of 1114, 1116, 1120 than those with the lowest African ancestry. And 75% of those patients had the 1114 translocation, which, as you may know, is a target for the new drug venetoclax, which is one of the more potent drugs, single drugs, in myeloma. There was a really interesting study that was published in Blood late last year that was done at Moffitt, and they got patients with myeloma, and they checked their peripheral blood, and they did whole genome sequencing, again, to prove or disprove, because some, not infrequently, patients will misreport their race. And that misreporting really happens, especially in Native American populations, where they may misreport them being a white when they're actually Native American and vice versa. So they confirmed their race based on whole genome sequencing. And then they got the myeloma cells, and they also did whole genome sequencing and RNA-seq. And what they found is that there were differences in genomic alterations between Hispanics in blue and African Americans in red, where Hispanics were more likely to have the IR4 mutation, which is associated with poorer prognosis and respond to the immunomodulatory agents such as Revlimid, thalidomide a little bit, and pomalidomide. And non-Hispanic blacks are more likely to have SP40, AUT, and there you are, and SET D7 which are associated, AUT, associated with lower overall survival among Hispanics and lower PFS and SP for a 140 among Blacks. And so again, and I think one thing that you can see is like KRAS, some of the other mutations like the KRAS, BRAF mutations were more common in whites. And actually, to go along with the deletion 17 being more common in whites and in Blacks, that P53 mutations were rarely found in Hispanics and in Blacks. So again, genomic differences between the races. And if you're only looking at alterations in this group, if you are having a lot of people in clinical trials with just these genomic alterations, you're going to miss a lot of information with those other racial groups. And so I hope that I'm convincing you that there are these differences, and enrolling diverse populations in clinical trials is the only way to get an answer of how this disease performs with all those groups. So disparities in clinical trials, I love this quote, that the ability to trust the results of clinical trials as well as transfer in the clinical practice is related to the type and number of patients enrolled in that trial. Because if trials don't include minorities, there's a question of whether or not the results are relevant to everyone across the board. Every time I talk to our fellows about applying a new research paper to patient care, I always ask the fellows, is the patients enrolled in that trial in that paper the same as the patient in front of you? Because the patient in front of you doesn't match the patient in that paper, you can't be completely sure that you're going to get the same results. One important point that actually I used to say all the time to people is how there are differences in cell lines. That cell lines are what we use to see if any of these myeloma drugs work, even before they get to the clinic. And most of the cell lines that we use in myeloma are from Asian descent, and the other half isn't reported. And African American cell lines only make up 6%. And then when you look at clinically, again, 20% of the US population are African Americans, but only 5% are involved in clinical trials. So we're missing a significant number of people. So in conclusion, myeloma has twice the incidence in Blacks and all other races, and is primarily due to the higher incidence of MGUS. I think I've shown you that there are some genomic differences that may have that higher risk, including a higher risk of familial onset of MGUS and myeloma from first-degree relatives of patients with myeloma. Blacks have a lower incidence of high-risk cytogenetics and possibly a higher occurrence of the 1114 translocation, again, that we use, that would be important targets for using venetoclax. There are differences in rate ethnicity of mutational burden, and I think I showed you in myeloma defining events. And to truly understand how myeloma occurs, and to eliminate some of these disparities, you need a better understanding of the differences. Because, when a lot of myeloma doctors are saying, that we're curing people with myeloma, and that's true. But in my definition, we don't cure anyone till we have cured everyone. And that's it. That's our hospital. I asked them to put a big Sparty thing on here, but they said no. Go figure.